Good morning. I'm Don Null. I'm the medical director at Primary Children's in Salt Lake City. I've spent a lot of my career dealing with respiratory issues and today we'll be discussing various modes of treatment for babies with respiratory problems. The first thing we're going to talk about is non-invasive ventilation. And the first part of non-invasive we'll talk about is CPAP. CPAP is continuous positive airway pressure. It's very similar to PEEP, which is positive end expiratory pressure, but on CPAP you're typically not intubated, although you can be intubated on CPAP and not have a background rate on the ventilator. The first thing with CPAP is to understand what CPAP actually does. And in the lung, from a functional residual capacity, we need to think about CPAP both from the early and late. Early meaning when you first apply it. What CPAP typically does is it does not recruit the lung, and I think one must remember that. That CPAP is a way to, once the lung gets recruited, to maintain lung expansion. And so when you first apply CPAP, you tend to overdistend the more normal lung, and the lung that's not inflated or is still atelectatic has to be re-recruited, typically when you're on CPAP by itself, by the patient. Late on, once the lung is well inflated, you may not need as much CPAP as you did early on, and therefore you can lead to a very high functional residual capacity, which may lead to some lung overinflation and some difficulty. So what does CPAP do to the compliance? Well, most people believe that CPAP improves lung compliance, and if you look at it early, that is not the case, because what happens is the normal lung is overinflated, and that decreases lung compliance because you get to the top of the pressure volume curve. And what has to happen is, as the patient breathes and opens up the atelectatic area, then the lung becomes more uniform. And so late on, late meaning after typically several hours, lung compliance becomes better on CPAP than it was before the patient was placed on CPAP. But that understanding is very important because you will not ventilate as well when you first go on CPAP, and sometimes you may not oxygenate quite as well either. CPAP can increase the work of breathing because you're breathing against a resistance and you may overinflate parts of your lung initially. From an airway resistance standpoint, adequate CPAP helps keep the airways open and would be felt to reduce airway resistance. So once the lung re-equilibrates to a more normal lung volume, airway resistance and work of breathing are significantly decreased on CPAP, as long as you don't get the lung overinflated. So what about the blood gases? So if you look at the blood gases on a baby on CPAP, if you look at the carbon dioxide level, when you first go on CPAP, so early on, the carbon dioxide level is going to increase. And again, the reason for that is because you've not inflated yet the parts of the lung that are poorly expanded, and you've distended the parts of the lung that are inflated, and that moves you up on the pressure volume curve. So for a given pressure change, you have decreased volume and therefore decreased minute ventilation, and so your CO2 characteristically will go up. So as long as you understand that, then you're not concerned about that when you put the patient on CPAP. What that should also tell you is if your CO2 is already 70, CPAP by itself is probably not going to be very effective because your CO2 is going to go even higher and your patient may lose their ventilatory drive because of that. Late on, because you get a more uniform lung inflation and an improvement in lung compliance, CO2 characteristically comes down to a normal range from that standpoint. From an oxygen standpoint, CPAP early on tends to improve oxygenation, and then it maintains oxygenation very effectively as the lung improves, and you are then able to wean oxygen. So if you're on 100% oxygen early on, you would expect the PaO2 to increase. Late, you would expect to be able to wean the FiO2 significantly and have a similar PaO2. Okay, well, let's move on to how do you deliver CPAP to the patient? Well, the most common route is using a nasal cannula. And there are various sizes for the very small preterm infant to the term infant. And these are very effective for delivering CPAP to the baby. Their problems, of course, are that they may have to be removed to be cleaned if there are significant secretions that break up. You cannot suction through them. And remembering, once you remove CPAP, you can lose some of the recruitment of the lung that occurred, and then re-recruitment has to occur. CPAP can be delivered by face mask meaning a bag and mask. So during resuscitation efforts or shortly after you've resuscitated a baby, you can hold the mask on tightly, and increasing the PEEP valve on that system, you can deliver adequate CPAP. There are devices now for small babies which are what we would call a nasal mask, so it's a mask that fits over the nose. The advantage of that is that it reduces the need for prongs sticking in the nose, and sometimes the very small baby, the prongs don't fit very well and can be irritative to the neonate. The nasal prongs that are used can be short prongs, which are the most common prongs that we use today, or they can be long, and they can either be small or they can be larger. The advantage to the long prongs are that they stay in the nose more frequently. So when the baby moves, you don't lose the positive end expiratory pressure there with the CPAP, and therefore that's beneficial because anytime you lose the pressure, you can de-recruit the lung. The problems with the long prongs are that you can build up a lot of mucus in the back part of the lung, and they can plug up, and it's not nearly as easy to see because you don't notice it until the patient isn't doing well, and then you pull the prongs out and you realize that they're plugged up, and so the baby's really not receiving oxygen or positive pressure under those circumstances. So if you're using long prongs, they do have to be taken out and looked at on a more frequent basis.